Thank you very much. Again, it's my pleasure to be here with you and to talk today on new trends of radiation therapy in breast cancer, and obviously we'll have some overlap with the other speakers. My apology before I start. I tried to figure out what other speakers would talk about and trim my talk accordingly, but regardless, I will have some overlap. But this is actually would be emphasis on the important topics. So this is the outline of my talk. I would talk about hypofractionation, but in a little, not details, just what's important for us in the practice. And I will also present the status of the data on partial breast radiation, which is also part of the trends in radiation therapy for breast cancer. It's a dying trend, I should say. When to omit radiation therapy, this is very important. We are faced all the time in our tumor boards about cases when to discuss the omission of radiation therapy. And a few words at the end about the new technology of DIBH that I urge you to use for breast radiation, especially on the left breast tumors. The trends in hypofractionation are gaining ground. These data are from the US, but there are similar data from Australia and other countries for both invasive cancer on the left and ductal carcinoma in situ on the right. The hypofractionation in red, so you can see that the hypofractionation is gaining ground. The top is overall use of radiation therapy. It's kind of like idling. And the use of partial breast is slightly declining for both the DCIS and invasive cancer. This is from National Cancer Database, United States. When you look at the location by centers of usage, academic and research cancer programs are definitely using more hypofractionation because they are more involved in the data development and reading, and also because of, unfortunately, of economical reasons, because reimbursement in the United States is related to the number of fractions, so people in the community are reluctant to lose some of their income. Now back to the STAR trial and the hypofractionation. I want to just show you one or two slides to show you that even when you use high dose per fraction, the 40 gray arm was actually a little bit better in local relapse. But the striking finding was that, surprisingly, it was showing better survival. So this was over 1,000 and 1,000 of patients, and people think, I am one of them, is this a true phenomenon? Is it really improving survival? Now when we look at the meta-analysis of this trial with other trials, I apologize for the fuzziness of the study, of the slide, but there was no improvement in survival on other studies. So when you put all meta-analysis, all trials, hypofractionation, actually there is no improvement of survival. We don't know why the STAR trial was able to show an improvement in survival. The second point of the difference between the STAR trial and the others is that the cosmetic outcome. This cosmetic outcome was better in the paper by the STAR group, showing in favor of the low dose and high dose per fraction, the hypofractionation. When we look again at the meta-analysis, the difference was in the acute reactions. As we saw in the previous talk, we see it every day. The patients do not have they have less acute reactions, but the cosmesis are equivalent. So we are happy with equivalence. There's nothing wrong. But so in terms of benefits of hypofractionation, you are shortening the treatment time, you are improving acute reactions, and late cosmesis, if anything, it's at least equivalent, if not better. So this is what we need to know and retain for the hypofractionation. The second point is that has been haunting us for many, many years. Can we use it for local and regional radiation therapy? And this has been really a dilemma, especially in the United States, where people were saying, no, don't use it because you have the brachial plexus, you have the arm edema, you have the heart, you have etc. And this is all really nonsense, because why we would have less late reactions in the breast and it would have more late reactions in the brachial plexus. I think this was actually not corroborated by studies, but now we have studies. My colleague showed this study. This is a recent study by the START investigators. They have treated 864 patients on those trial with the hypofractionation with regional nodal radiation. So 864 of the 5,000 something had patients treated by local and regional radiation therapy with hypofractionation. And you cannot see it from the back, but on top is arm edema, on the bottom is shoulder stiffness, and there is no difference. So the START investigators were able to demonstrate in a recent paper that you can treat regional nodal radiation without any problem. The second study, which was presented at ASTRO this year, is a randomized studies from China, randomizing patients, 820 patients, to post-mastectomy radiation therapy with conventional or hypofractionated radiation therapy. No difference in local regional control, better skin reactions always, no plexopathy in both arms, and similar rates of lymphedema. So I think the fear of having more lymphedema and more brachial plexopathy is unjustified. And in my opinion, we can safely recommend hypofractionation for post-mastectomy radiation therapy and treatment of the regional lymph nodes. Moving on to the breast partial radiation, what we know now about partial breast radiation, many papers have been, and trials have been developed on partial breast radiation. I will just summarize some of the data. I will talk only about the brachytherapy trial and the conformal radiation trial to avoid overlapping with other speakers. The JAK-ESTRO trial is a trial that was published last year, or actually more than a year now, that looked at 1,184 patients in many countries and several hospitals comparing whole breast radiation versus partial breast radiation using brachytherapy. And the data is out now. It is equivalent, is non-inferior, at least local control and survival are inferior. And in terms of rate effect, there is a mild benefit in favor of the brachytherapy, obviously, because they have less pain and moderately better skin reactions. And this is the late effects actually on this graphic presentation, slightly in favor of, not slightly, clearly in favor of the brachytherapy patients. So at least no difference in outcome, at least non-inferior for the brachytherapy with slightly better late effects. Now the second methodology, which is more common, because brachytherapy is actually very difficult to develop and you need a lot of expertise. In 3D conformal and IMRT for local partial breast radiation is simpler, and this is the most commonly used technique. We have data on early data from Canada on the RAPID trial. Many people are familiar with this. This is from 2013, when they compared whole breast radiation therapy to the local partial breast radiation therapy using 38.5 gray in twice a day for 1 week. And the first report available to date is on cosmesis. And here, the partial breast radiation was inferior to the whole breast radiation. This is on the left is a partial breast. You can see the poor and fair plus poor is kind of like more than on the whole breast radiation therapy. And also for telangiectasia, fibrosis, and pain, you have some about 12 to 13% in the partial breast radiation versus whole breast radiation. Probably related to the intensity of the radiation. It's given twice a day, it's large dose per fraction, to a relatively significant volume of the breast. When you talk about 3D, your volume of radiation is not that small. It's actually at the end you end up treating almost half of the breast. So I think this is what is causing this finding. We have the famous NSABP B39 trial that we have heard about it many times. We are still waiting for the data. The report has been, the accrual has been completed, and we are waiting for this famous trial to come out to see if this partial breast radiation is as good as whole breast radiation. radiation. Now, there has been a meta-analysis recently of all the trials, including the intra-op, the brachy, and the rapid trial. This is shown on this slide. And the meta-analysis has shown that actually the local control is favoring whole breast radiation therapy compared to partial breast. Probably most of you know why, because the two trials on intra-op have been negative in favor of whole breast, and this has drifted the data toward the whole breast radiation therapy. And this is free survival over survival, no difference. So moderate decrease in local control when you look at the meta-analysis of all trials with partial breast radiation therapy. In cosmetic analysis, then we have the patient reported, the trained nurses and physicians, and they were all in favor of the whole breast versus partial breast radiation. The cosmesis is actually a problem that we have to keep in mind in the when we are using partial breast radiation. The fast forward trial, we heard about it. I think this is a very provocative, very nice approach. It's actually combining extreme hypofractionation, but for the whole breast, not for the partial breast. This is the UK study that we heard about. It is now, the phase 2 pilot study has been published showing that it's feasible. The randomized trial is ongoing. It's randomizing the hypofractionation, which is a standard arm, compared to 27 or 26 grade in 1 week. But it's whole breast. I think this is very important to track and find out if this is going to come out a positive trial. Now, in the interim, what is the trend, what to do? We have a lot of consensus criteria from ASTRO, Jack Astro, ABS, and the Society of Breast Surgeons. And when you look at all these criteria together, there are some overlapping criteria. So for patient more than 60 with early breast, negative margins, no LVSI, no extensive DCIS, ER positive, and no lobular, no neoadjuvant chemotherapy, for those criteria that are combined with all these criteria, it is safe actually to recommend partial breast radiation. Other than that, we have to wait for this famous NSAID trial to find out if it is safe to deliver partial breast radiation. And I will close on talking about when to omit radiation therapy, when not to give radiation therapy. As I said in the beginning, we are faced in this situation very frequently in our tumor boards. And I will just show you the famous old trial, now CLGD trial, that looked at partial mastectomy tamoxifen or partial mastectomy radiation and tamoxifen, trying to take radiation out. And it was showing that local recurrences are 2% with the combination and 10% with tamoxifen. So we have to tell the patient that if you decide not to get radiation, you are losing some points in local control. Some people are willing, especially very elderly, not very mobile, living very far from centers, they may accept that. But if they are available and close to the hospital and they are in good shape, I think better take the 2% than a 10% local failure rate. Now the Canadians have looked at the same problem and found similar data, but they also looked at the molecular subtypes. And I think we'll hear more about it later on in this session, just to show you that luminal A, actually radiation therapy is improving the outcome in all type or molecular subtype, particularly in the HER2-enriched tumors. But if you want to miss radiation or omit radiation, I think better do it only for luminal A, because here the difference is very, very small. So I think if you want to omit radiation, for elderly people, I think you have to make sure that the patient has a luminal A profile or molecular profile, which would be safe to omit radiation. And finally, I will emphasize the protection of the heart is very important. It's not allowed anymore to include the heart in the tangents for left breast tumors. This is a crime, because we know the data from the Darby and colleagues that for every gray you deliver to the heart, you have 7.4% excess of cardiac toxicity, and that lead to mortality. The DIBH, or deep inspiration breast hold, is one technique that's very easy to have and to implement, showing how the heart will change from proximity to the chest wall by the deep inspiration, inflating the lung pushes the heart away from the chest wall and allows you to deliver. This is without normal breathing, and this is with deep inspiration, allows you to deliver radiation safely to the left heart, to the left, chest wall or left breast, without losing any coverage on the chest wall. So in fact, deep inspiration breath hold improves heart and lung doses by improving the mean dose to the ipsilateral lung, eliminate the dose to the heart, and with no change in the dose to the breast. I think I will stop here and I will take some questions. Thank you for your attention.
Any question? I have one question for both speakers. First speaker, ready. I think now we are talking about hypofractionation, and I think this is my belief. Can we start using radiobiological optimization as a treatment plan instead of physical optimization to take into account fractionation and also tumor type and all the radiobiological parameters?
What do you mean by tumor type?
I mean alpha over beta ratio.
Yeah, by using radiobiologic optimization and treatment planning, it's actually not, for me, it's not a correct science, because we don't have all the facts for, if all tumors do not behave the same. We know in general that hypofractionation is good for all breast cancer, but how to optimize for patient A or patient B? How you're gonna boost or give less radiation or more radiation for this patient? We don't have data on inter-patient variability. We don't. We know, as my predecessor showed, that the alpha beta is around 4, so we can't do it for everybody. Can we do it for patient A, not for patient B? Can we change the optimization? I don't think we have information on individual patient data to do it. We don't have data on we have the molecular profiling. We will hear more about it later on. I don't know if we can use this, at least this is how I see it, this dose modeling or optimization using molecular profiles. I'm not aware of studies in this direction.
Perhaps, but today not.
Thank you very much.
Let's talk. Dr. Maya.